Good evening, everybody. I'm Claire Freeman. I'm a consultant pediatric surgeon, and I'm here this evening to talk to you about one of my core values, one of my favourite topics. And it's probably not one that you'll be expecting to hear from a pediatric surgeon. And I'm here alongside my colleague, and I'm going to let Nicola introduce herself first.
Hi, I'm Nicola, or Nicola Burt. I work currently as a staff podiatrist in Nottingham in podiatric surgery. I've known Claire for many years now, and we've done a few of these shows together. So I'm really looking forward to this new aspect of podiatric surgery, really. So Claire, I'll let you introduce the topic because I actually find it quite interesting, this.
So, as I said before, I'm Claire Freeman. I'm a consultant pediatric surgeon. I work part-time for a company called Independent Health Group. And in that job, I do NHS work only. And I also have a private practice where I work at the Newhall Hospital in Salisbury, which is a Ramsay hospital. I just work there one day a week, and I see a wide variety of patients within my case mix. But I would say that I specialise in forefoot surgery. I'm an elective surgeon. I don't do trauma, and I don't do very much high-risk work either. And that's kind of the background towards the work that we're going to talk about this evening. Mike, have we got the slides showing? Aha, we have got the slides. Lovely. So this evening, I'm going to talk to you about a subject which is one of my core values and one that I'm really passionate about. And it's the principle of lifestyle medicine. Now, not many people have heard this phrase, lifestyle medicine, but what I want to do is introduce this topic to you this evening. And I'm also going to talk to you about why this is relevant to podiatry and in particular to myself as a podiatric surgeon. And hopefully to get all of you to consider this as part of your practice and see that it's something that you can incorporate in your practice as well. So I'm going to run through a whole series of slides. It's going to be mostly me talking, but Nicola is going to assist by asking some pertinent questions as we go along. And what I would really like is, as we go through, if anybody in the audience or any listeners have any questions which they'd like to pose to us, then please put it in the chat. Nicola is going to be monitoring that, and as questions come in, she will put them to me, and between us we will try and answer them. I'm not going to pretend that I have all of the answers myself, but what I hope to do is to introduce a whole load of topics to you, the things that you'd like to go away and study, look at, investigate further yourself. So
I'll probably butt in a little bit, don't mind.
Right, of course you can butt in. I mean, it's much more fun. Otherwise,
here we go.
I'm thinking that nobody's listening if nobody actually talks to me.
That's fine.
So,
I was just about to say, because I've seen actually on your on the side now, what is lifestyle medicine? I was just going to ask you, what exactly is lifestyle medicine, and what does it mean? What does it mean for podiatry and podiatric surgery?
Okay, so I'm a member of the British Society of Lifestyle Medicine. Now, I'm not an associate and I'm not credited, but I am a member of it. And I signed up to this association last year because they started releasing lots of really interesting topics about things which are just on the fringes of medicine. And it's a whole completely different philosophy about maintaining good health rather than just treating poor health. And this is something which I've signed up to the whole of my life. I do believe that we can do so much about maintaining our own health rather than expecting somebody else to keep us healthy. And this movement is all about encouraging those people who come from medical backgrounds to encourage patients to do these things, to actually optimize their health. So is it important to the general population? Yes. Is it important to anybody who works in medicine? I would say yes as well. And is it important to people who work in pediatric surgery? I think it's very, very relevant. And even though I've been qualified for many years, I have learned so much in the last year about how to manage patients and how to put things into perspective and how to really get patients to get the best quality out of their life as well as the quality of whatever work I'm doing for them as well. So I think the important thing about lifestyle medicine is it recognises how certain activities are interrelated. It's evidence-based. A lot of people think it's sort of woo-woo and wacky and all the rest of it, but all of the work is evidence-based and it's person-centered. And the society have split this down. So there are 6 pillars which make up the activity. So within those pillars, there's physical activity, sleep, healthy eating, reducing harmful substances and behaviours, social interaction, and mental well-being. So I quite like the line mental well-being rather than mental health, because we all have health. When we say mental health, it makes it sound like it's poor health, but actually mental well-being is a much more positive way of putting that. And I think there's a lot of this sort of ethos of how this works is about being positive about things. So
this is really interesting because it's almost like a combination of sort of a mindset and general promotion of self-care. And I think that's really, really positive to kind of think about it in that way, because I never actually thought about mental health versus mental well-being. It's like these slight phrases that make all the difference, really, isn't it? Especially when you're treating patients can kind of word things. Or, you know, you get challenging patients sometimes, don't you, when it comes in, how do you go about promoting nutrition, and how do you go about promoting, like, for example, discussions about weight and these kind of things. So, you know, that's it's a difficult one, isn't it? But trying to sort of promote that self-care and independence, and a non-reliance really on, you know, even things like NHS streams and these kind of things. But it's definitely, definitely useful when it comes to thinking about patients as a whole, and not just the foot, what you see in front of you versus the rest of the patient.
It's not only the nuances of the words you use, it's how you use them and how you approach your patient as well. And there's so much about positive suggestion that you can put forward. And I'll talk to you a little bit more about that as we go through the slides as well. So we're going to move on to...
So you said about...
Go ahead.
So you said about 6 pillars. I was just about to ask which ones would you be sort of talking about first, and healthy eating.
Okay, so I kind of skimmed over the 6 pillars, and these are the sort of the standard things within lifestyle medicine. So the first one I want to talk to you about is healthy eating, and this is a subject which is very dear to my heart. A lot of people have considered me a picky eater or a strange eater or whatever, but I have very clear principles about the way I eat myself, the type of foods that I eat, and the health that I maintain from it. And I do believe that eating a healthy diet can make such a difference to your general well-being, but also about how well you recover from certain illnesses or episodes which happen in your life. And this is something which is kind of really, really important to me, because with my patients, I know that those patients who are well nourished will be in a much better position to manage any trauma. In other words, surgery, because surgery is a trauma to the body. So they'll be in a much better position to manage that if they're really well nourished. And I'm going to talk to you about some very specific things within healthy eating. So to put that into a little bit of context, there's I think I need to go back one, maybe. Oh, I can't remember where I've put... perhaps I didn't include it, but anyway, there's a particular clinician who's written a lot of work about nutrients in diet, and one of the key subjects that he's talked about is Menterio et al. And there's a reference at the end of this, and he's written a lot of papers about ultra processed food. And he has produced some work which shows that over the years, the percentage of ultra-processed food that the population is consuming is increasing. Now, the problem with the ultra-processed food is it's higher in salt and in fat, unsaturated fat and carbohydrates and sugar, and it's lower in the proteins and the fibers and potassium, which are the things which are really key to our diet. So our diet nationally and internationally is changing with these ultra processed foods, and there's a lot of work which has been done about encouraging people to eat an unprocessed diet. So I'm sure that lots of people have heard of the Mediterranean diet, and this is where people use a lot of freshly grown vegetables cooked in olive oil, and there's something about the anti-inflammatory products which are and the reducing oxidative stress with the polyphenols which are in the colourful fruit and vegetables, and there's a sort of an alchemy of when you cook things in olive oil, which means that you preserve the nutrients better and you're better nourished from it. And I think as a society, we've tended to move much more towards sort of processed, quick, fast food, whereas in actual fact, it's so quick to, you know, fry some courgettes or something like that, which will be going back to a sort of much more basic style of eating, moving away from these ultra processed foods. So there's all this sort of evidence around diet and nutrition. And one of the really interesting things that I picked out of a talk that I was listening to by Dr. Simon Poole on the Mediterranean diet was that a glass of red wine drunk in company is more nutritious and more beneficial to you than a glass of red wine drunk on its own. And how they
like
amazing. I think it's this thing about the social interaction, and that's one of the key things that runs through lifestyle medicine, is the fact that, you know, the 6 pillars, they don't stand alone. They're all interrelated. You can't just say, right, from now on I'm going to eat a healthy diet and therefore my lifestyle will be better, but actually all of these things are interactive. So there's this thing about, you know, drinking red wine, and the social interaction which goes with that is about healthy relationships as well. So you can see there are a lot of links. So it's difficult to sort of divide everything up, but there are a lot of links between these pillars of lifestyle medicine. So in talking about how this really relates to pediatric surgery and my patients, there has been quite a lot of evidence which has come out, particularly around vitamin C. Now, there's this really good paper which I put up here, which was a randomized control study. And this showed that those patients who took 1 gram of vitamin C, which is equivalent to one of these effervescent tablets per day, had a reduced incidence of complex regional pain syndrome following surgery. Now, complex regional pain syndrome is a rare condition, but if and when it happens to a patient, it's really significant. So, you know, for the effort of taking one of these vitamin C tablets, reducing the risk of getting complex regional pain syndrome, I mean, I just think it's a no-brainer. So this is something which I advise.
Why wouldn't you as well? That's so good.
Yeah, absolutely. I say to them, have a really healthy diet, have all these fruits and vegetables which are lots of colours in them, and using natural oils to cook in, and make sure you boost your vitamin C and your vitamin D, and you have lots of fibre in your diet as well. And there's all this evidence behind it. So this is how it relates particularly to pediatric surgery. And then if we look at vitamin D is a really, really important element in many ways. And there's a lot of research which is coming out about how vitamin D affects many different mechanisms within our body. But one of the key things is about bone turnover and bone healing. Now, if vitamin D is low, then you are at a higher risk of a non-union if you have a fusion surgery. Now, we know that in this country, between September and March or so, we don't manufacture vitamin D through sunlight in our skin, because the sun is too low in the sky. During the summer months, we build up some vitamin D, but we don't store it. We lose it. So come December, January, our vitamin D levels are very low. And this can mean that patients are much more at risk of a non-union. And non-union is a really significant issue. If I'm going to do, say, a hallux valgus surgery and I want to do a tarsal metatarsal joint fusion to do that, and this patient is vitamin D deficient, and they then go on to have a non-union, then that could be a bit of an issue, well, a huge issue for the patient. So just to put this into perspective, this was one of my patients, and I operated on her in the summer months. and I didn't do a vitamin D check on her. This was several years ago. We've changed our policy since this on the back of what happened with this patient. So if you look at the first X-ray, you can see that I've done a first tarsal metatarsal joint fusion. I've also done an aching as well. And actually, when you look at it this view, it looks like it's fused, but she was coming back, so 6 months later, still in pain. And it wasn't until I took an oblique view X-ray that you can see here that there's a non-union here. So after she'd had physio and all sorts of other stuff as well, we then did some bloods on her, and we found that her vitamin D level was insufficient. So we boosted her with vitamin D. I went and I took out the metalwork as well, because I felt that perhaps it was slightly elevated there. And actually you can't see it on this image, but in fact the screws were broken, which is something which is common when you get a non-union, and then the plate can lift and that can cause additional problems. So I took out all of the metalwork, boosted with vitamin D, and she's gone on to make a really good recovery. So the long and short of that is I now check all of my patients. If I'm going to do a fusion, we do bloods, we check their vitamin D levels. Even in the summer, I'll check the vitamin D levels, because there are some people who will be deficient. And I think it's a good plan to know that before you operate on them. So I think that's all that I want to say about diet and healthy eating. So I'm going to move on now to the next slide, and I think that you've got another question for me.
Yeah, I was going to say, so you think that there's like a link between nutrition, healthy eating, and I say mental well-being rather than mental health, really, because you said that there's like a clear interlink between them all. It's very difficult to just dissociate one from the other, really, isn't there? It's much like what you were saying about with a wine socially. That is better than a wine alone. But I'm just wondering how then that all interlinks. So I can understand how the diet very much is associated with podiatric surgery, but I guess then all of that has an interlink with mental well-being as well, doesn't it? Because how your patient must have felt when she found out that, you know, perhaps that she didn't that she was a bit vitamin D and that was the cause of, you know, her healing. Could that have been resolved just by healthy nutrition beforehand?
I mean, it is a good question, and she was an anxious person anyway, and she was really, really stressed about the fact that she felt that she should have been better and she wasn't. And comparing her to another patient I had, who was a lady who was very fit. She was a runner, and she was very into healthy eating. And I did the same procedure on her, and I think something like 9 weeks after I operated on her, she ran 5 miles on the beach with Joe Wicks. I just thought, what a difference between the outcome of this patient and the other patient. And I'm sure it was partly to do with the fact that she was really, really well nourished, and the fact that she was very physically fit, but also she had the mindset without stress or without anxiety that she was going to get better. So mental well-being has a real effect on how people cope after their operation. And I think that this is something that I work really hard to make sure that I reduce stress levels as much as I possibly can with patients. And that can be really quite tricky, because everybody reacts differently. It takes a real skill to actually pitch things which are right for the patient. So what we do know, again, is that vitamin D is related to mood states as well. So, you know, vitamin D plays lots of roles within the body, and this is just one of the ones which, again, I think is pertinent to this mental well-being, that people who have a low vitamin D level may be much more prone to problems with their mental well-being. So, you know, that links those two together. But also sorry, go ahead, Nicola.
No, I was going to say, because that's almost like saying, in effect, because you know you hear this saying called SAD, like that SAD syndrome, don't you? Like when, especially in, I guess in this country, people are just generally more aware of it. The fact that, you know, when there's less sunlight and you've got less vitamin D exposure, all of that kind of thing, you just feel really not not the best, do you? You're like, oh, I just couldn't live for a bit of sunshine. But yeah, it definitely does affect your mental well-being, but you kind of wonder how much of that is purely down to vitamin D deficiency and how much of that is actually purely down to your mindset. You know,
and also you've hit on something which is very interesting, which I'll talk about a little bit more later. It's about convening with nature and being outside as well and getting natural daylight on you, because that can have an amazing effect on your well-being, not just your mental well-being, but your overall well-being. But I'll come on to that in a little bit when I talk a little about physical exercise. Just going back to the mental health bit, there was this really good paper that I found, which is about management of mental health in orthopedic patients, which was in the Journal of Bone and Joint Surgery. And what they're advocating is that there should be a mental health evaluation of all patients before they have their surgery, because those people who are in a better state of mental health are less likely to have post-operative complications. Those people whose mental well-being or mental health is less than optimized are more likely to have those post-operative problems. So it's in everybody's interest to manage those things beforehand. And there are ways and ways of doing that, not just saying to people, oh, you need to go and see a psychologist or whatever. You know, that I don't believe that's my role to do that, but there are certain ways that you can encourage people to be much more positive and much more signed up to a procedure which they're going to have. And sometimes I joke with my patients, and actually I'm a huge believer that humor is so important, and if you can have a bit of a laugh with people, and I don't mean to be trivial at all with them, but if you can make people laugh and make people trust you, then that does have a very positive and lifting approach. And one of the things I say to patients is, if you're in any doubt about this surgery, don't have it, because I want you to be completely signed up, because it makes my job so much easier. You know, if you're signed up to this and this is what you want and you've decided it's right for you, then it's going to go well. And unless you fit those things, we know that there's going to be some issues along the way. And this is really about their state of mental well-being. Just to give you some ideas of what I feel are ways of really improving your mental well-being. This is me in January deciding that I really wanted to do a little bit of tree hugging. I'd been out for a really amazing walk with my husband and just saw this tree, and it was calling me, saying, come and hug me, come and hug me. And it was, you can see I've got my bobble hat on and my mittens. It was a really, really cold day. But I think just being, as I said before, just being outside in daylight, and I think the idea of getting daylight in the morning or by lunchtime is a sort of different quality of light, and it helps to set your circadian rhythms and things like that. So yes, get out there, get out into nature is such an important thing to do. And then the other side of that as well, you know, I said that I think that laughter and humor is just so important. So this other slide is a picture of a patient of mine who I had for clinical reasons decided to put in an air cast boot for 6 weeks. And when he came in to tell me about his progress, he took his boot off, and I just roared with laughter, because I mean, what a fantastic pair of socks. And his mother-in-law had knitted these for him. And thought, yeah, rainbow socks knitted by his mother-in-law, and I just thought, you know, if that doesn't lift your soul and make you laugh, that it was just such a great thing, and he was very, very kind and gracious, and let me take a photograph of them as well.
I have a thing about socks. I think socks can tell a lot about people. Yeah. If you see someone with a really funky, quirky pair of socks, you can generally tell a lot about this human.
Okay. So obviously you've not seen my bee socks. I'm a bit of a bee fanatic. So yeah, I do wear socks which have got bumblebees on them.
all for saving the bees.
Okay, so I'm going to move on now to the next section. Oh no, I'm not quite going to move on to the next section, because in this slide, what I'm showing you is this is me doing an ankle block on a patient who actually had a learning disability, and he was so cool. He was so signed up to the procedure. And he had capacity. I wouldn't have gone ahead with this procedure unless he had capacity. And, you know, it can be a really stressful environment because he's in the theatre. I've got the ultrasound out. I'm doing an ankle block using the ultrasound. There's all these bits of machinery going bleep, bleep, and lights going on and off and all the rest of it. And so you can see my ultrasound in that picture, and in the picture next to it, you can see me really concentrating hard on the image on the screen while I'm doing the injection. So I think in the first one, you can just about see the side of my nurse here. So, you know, we generally have a nurse who will talk to the patient, hold the handle, do whatever is necessary to reduce their stress levels. And I have on several occasions done some yogic breathing, or sort of monitored breathing or counted breathing, those kind of things with the patient. And you'd be really surprised how much you can relax somebody just by doing some really gentle exercises, and reassuring them that everything's going to be all right, and that, you know, if they count to 10, it will be over by the time you get to 10. And doing those breathing things can make such a difference to the adrenaline levels, and then how they experience the injection and things like that. So, you know, this is all part of managing people's well-being, is managing their stress levels in the theatre as well as before and after the theatre as well.
I think it's a real skill though, isn't it?
What, being able to talk and inject at the same time?
I was just going to say, it's a real... Well, be able to make a patient calm under such a stressful situation, not only for them, but it can be very stressful for yourself as a member of staff, really trying to get it right, making sure that your anesthetic block works, making sure that it's, you know, least painful for them. You know, already it's going to be a painful, you know, injection, but, you know, just making sure that also you're doing the right thing, and also minimizing stress for both yourself and the patient. That's a real art, 'cause you've got a needle in your hand whilst you're doing everything else as well, you know.
Yeah, well, I'm sure you've been in this position because you're a specialist podiatrist. You do lots of blocks yourself, don't you? So are there any particular techniques that you use?
Well, I'm thinking about bringing it. So we have a little stress ball, which doesn't actually do too much, but we do have nurses as well on hand. So we've got like our lovely HCA support staff, and they just do the most fantastic job, you know, with our patient. They are just so kind and just so relaxed and very personable. Yeah, I just love them to bits. They're just so awesome. But they do a fantastic job at supporting patients. But I think we also have our certain techniques between us all to try and, as you say, just make your patient laugh a little bit, gain their trust, and just really talk them through certain things. I also think that it's the power of understanding, and that just goes across board. Like if a person doesn't understand why they're doing something or why they shouldn't do something, you can never fully expect them to sign up to anything completely, because they just don't know what they're signing up for. So you know, you kind of expect when things don't go quite to plan, you know, it's all about that honesty from the get-go. And yeah,
sure. So we've already touched a little bit on healthy relationships. Did you have a question for me on this one?
I think so. So I wrote some questions down, actually. Sorry, my screen's yeah, so we all like to think that friends and family are important, but what's the view with the relevance to podiatric surgery, why it's really useful to have healthy relationships?
Well, there are so many risks associated with people who don't have healthy relationships, and I think that by healthy relationships, that's, you know, relationship with friends and with family and with social groups. It could be church groups, or it could be groups of school friends or work colleagues or anything like that. And, you know, I think we all get different things from our different relationships. whether it's family or friends or work or whatever. But I think that really the relevance to pediatric surgery is about the risk factors that there are if we're going to operate on them. So this is just off the top of my head. It's a sort of list of things which I consider when I talk to a patient, and I do ask some questions which some patients find really strange, and I'll say to them things like, do you live on your own? And sometimes a patient will think, well, that's a bit personal, isn't it? I'll live on my own if I want to. You know, do you live on your own? And the reason I'm asking that question is, you know, who's going to bring that patient to and from their appointment? What's the transport situation? What's going to happen when they get home? Is there somebody who's going to make them cups of tea and make their dinner for them and look after them? Is there somebody who's going to make sure that they eat that lovely balanced diet of Mediterranean foods and cooked in olive oil and take their vitamins, as I've been suggesting? Are they going to be able to rest with their foot up, or are they going to be pottering around the house trying to get their own things done, or, you know, get the vacuuming done? You wouldn't believe the patients I've had and the things that they've got up to after surgery. And then, of course, one of the really, really pertinent things is medication management. So, you know, if a patient's going to need pain control once they get home, if they run into problems, you know, who is there to monitor what they have and haven't taken? Is there a trip hazard in their house? I ask patients this. I said, do you have a downstairs bathroom? And they're and again, often they kind of look at me and say, why do you need to know that? Well, you know, because in my mind, I'm thinking, if you're going up and down the stairs every time you need to go to the toilet, that's going to be a problem, especially as I'm going to be getting you to drink lots of water as a DVT prophylaxis. But if they can get from their couch to their bathroom without having to negotiate hazards such as trips and rugs and stairs and things like that, you know, those sort of things are really pertinent to the patient. And, you know, perhaps if they have risk hazards such as rugs, you know, if they have a wife or a husband, they might be able to roll that rug up so they can make their journey to the bathroom and back without undergoing that hazard. And I don't think that we can reduce the necessity for emotional support. You know, I know that, you know, I have a very good friend who's been really poorly recently, and it's made such a difference to them having friends who just call and say, how are you doing today? Or, you know, do you want me to bring you round a cake or not cake, of course, we don't eat cake.
Lots of cake, lots of that.
Let me bring you around some flowers, or something along those lines. But emotional support is really, really important to patients' recovery and then mental well-being.
Oh my gosh, it's such a thing.
And then, you know, the other thing is, you know, if somebody is having problems, sometimes you need somebody to speak up for you, to say, you know, because I know that I've had patients who come and say, yeah, it's okay. And their wife is nudging them saying, no, it's not. Come on, it's not. You're not sleeping. So, you know, tell the truth here. So an advocate is really important. And this is all about whether they have that relationship with somebody who can say that for them. And then last but not least is the animals.
I love this picture. As a horse person myself, and I absolutely love that.
I say that if patients have dogs, I say, please don't let your dog lick your wound better, because it's not going to be much good. And dogs will want to do that. They'll want to love you better. You wouldn't believe the number of dressings that I've taken on which have got dog hairs right down through, you know, six layers of crepe bandage, and there's dog hairs in the wound. Then I've had patients who said, but there was nobody else to muck out the horse. I had to go and do it.
Gosh, yeah.
On my crutches. I'm sure you've come across patients like this as well, Nicola. But you know, animals, yes, they give you unquestioned love and support, and they're lovely to have, but they can be work as well, and they can potentially be not beneficial to you. But having a relationship, we all know that a relationship with an animal can be very, very beneficial. So all of those things are potential risk factors in terms of people's mental well-being. Okay. So,
I was going to say, can I jump in, Claire?
yes, of course.
Because I think it's really interesting to come across, obviously, from your side as podiatric or as a consultant, and I guess how you see them then from the new patient assessment. So from my take as like a staff podiatrist, obviously doing pre-op assessments, our first question would be, do you have good home support and transport? Who's going to bring you to your procedure and take you home, look after you, etc. So we often get sort of the same sort of eyebrow raising, like, well, I'm quite independent. I live on my own. I can do everything for myself. And it's entirely that conversation of just like, I don't know if you guys proceed if they haven't got appropriate home support, but we just, unless it's convincing that they're going to have at least the first 24 hours, 48 hours of home support, you just can't, because it's just not safe. Like, and then just letting them understand, right, this is because your rest duties will be 2 weeks, toilet and back, and then that's it. And this is why we need you to have the, everything in place. But,
You're absolutely right. And sometimes it's heartbreaking when you have a patient who doesn't have anybody that they can call on or rely on. And it is heartbreaking. I don't think there have been, I think there have been a couple of times when I've decided it's just not safe for us to proceed in a community setting. And if this patient really, really needed surgery, then it would have to be a admitted patient. I don't have the facilities to admit patients for post-op care. So, yeah, I think it is important. And very often people will find somebody who will be able to come and stay with them for at least 24 hours. But there have been a couple of times when, but it breaks my heart when, particularly with older people, when they've maybe lost their partner and they don't have family to rely on and have lost a lot of friends as well. It is a very sad thing to have to deal with. Very sad. So moving on, we're going to move on to a bit of physical activity. Yay!
The power of movement.
I'm going to get up and stretch now. It's interesting because one of my nurses went and did a wellbeing course, and she said that one of the things they were taught was that they should all stretch while we're doing our morning meeting, because we have a meeting before we start a theatre list. We all get together and talk about the cases and the details of it and the rest of it. And for about a week, I think I got them all doing some stretches as we were doing our morning meeting, but then I'm afraid it went by the by. But every now and again, I kind of remember and I get everybody to do a little stretch. They all think I'm mad, but
No, honestly, I say the word stretch in our department, and some people are just like, "What's that?"
Okay, so we're going to ask me something about physical activity, or shall I just launch straight in?
Give me 1 second. So I just need to upload my questions. Is there any evidence or change in the guidelines about physical activity?
Well, now you mention it, there have been some very new guidelines which have been published in March 2023, and this is by the UK Chief Medical Officer, guidelines about physical activity and the communications within all of the stakeholders of this. So I think that they're beginning to realise that being active is so important. And we've already talked about getting out into the sunshine and being out in nature. But there's more evidence coming through about the effect on the whole body of this. And I know that the first line of treatment for hip and knee osteoarthritis is activity, is exercise. So when there's very little written about the foot as such, but if you extrapolate that and say, well, if you have osteoarthritis of the first metatarsophalangeal joint, hallux rigidus, like if you've got arthritis of the hip, should physical activity come into it? Well, that's a really difficult one. If you've got patients who have problems with their feet, it just makes it really difficult for them to get out and exercise. So there was this really good paper here which showed that limitations in mobility and independence are psychosocially devastating, represent a huge economic challenge to the sustainability of health in the healthcare system. So what we know is that if people are less active, then they're more likely to have osteoporosis, and they're more likely to get those non-communicable diseases such as musculoskeletal problems, osteoarthritis, and the knock-on effect of that. So keeping people active is so important, and I think that there's been some very new evidence out to say that the habit of activity, which is formed in early years and adolescent years, is something which sets people up for life in their activities. So all of those kids who are going out there playing football and getting involved in gymnastics and things like that, you know, that is so important. But I think that, you know, a lot of us who have very sedentary jobs, it's very easy. Well, I don't count mine as a sedentary job because I stand most of the time when I'm operating. But I think that it's very easy for people to get out of the habit of exercise. And exercise has, you know, knock-on effect on your sort of your mental well-being as well as your physical well-being as well, and is a first line of treatment. So you know, just this is me climbing in the Dolomites, just to show that I do practice what I preach, and you can see that it's actually really up high, and it was quite difficult. You know, the oxygen saturation, I was really beginning to feel the pressure up there, but it was a huge achievement getting up as high as we did, and just what a fantastic view. I mean, I can't imagine how anybody couldn't be uplifted after they've been experiencing that kind of a view all around them and all of that oxygen that you're breathing in. But if you've got a foot like this one, how are you possibly going to be able to do that, you know, that kind of exercise? I mean, you know, I have this is one of my patients, and when you've got something like this, they can barely get a shoe on and they can barely get down to the shops, let alone climb the Dolomites. And this is why I think that podiatric surgery is so pertinent in terms of physical activity, because if your feet hurt, you don't do it. And therefore, my view is that it's better to correct the structural deformity so that people can get out there and exercise. And I'm not saying, I mean, that you know, this was a lady in her probably 70s or 80s, and I'm not saying that she would be able to climb the Dolomites if I operated on her foot, but she'd be in a much better position to continue being more active and meet her own expectations of being able to get a shoe on comfortably and actually get to the shops and back, which for some people is their expectation or they want to be able to do. But what I want to do is I want to encourage everybody to get out there and walk and walk and walk and walk, because that is what our bodies are designed to do, and the massive health benefits that go with that fit very neatly into the lifestyle medicine. So just to give you a little idea about what I was talking about what kind of surgery. So this top x-ray, you can see the first metatarsophalangeal joint. This is a stage 4 hallux rigidus, complete loss of joint space, widening of the bones there, sclerosis, and very painful. So this is the patient who is marked up ready for surgery, and you can see that there is a significant enlargement of that joint. So I was planning first NTPJ fusion, and this is an interoperative image. So toes are down this end, ankles this end. This is the shaft of the first metatarsal. Look at that huge exostosis around the dorsum of the first metatarsal. I mean, no wonder this patient can't get a shoe on, let alone walk as they want to. So this is why when people say to me, oh, well, you know, if you fuse that joint, I won't be able to walk, will I? I said, well, actually, that's not true. Fuse the joint and you'll be able to walk a lot better and you'll be able to get your shoes on. So I do believe that podiatric surgery, operating on feet, fits very clearly into lifestyle medicine, because the principle of it is to keep people mobile and keep people moving. So we're gonna romp through a little bit because we've had such fun chatting that I haven't got through quite as much as I should have done. So yes, so next question.
harmful substances. So what do you count? Well, obviously we know that things like smoking and alcohol, that's very much abundant in harmful substances. Would you class anything else in terms of harmful substances? I know that you've already touched on, like, say, poor nutrition, but what do you class as harmful substances?
Okay, so this is interesting because it's harmful substances and behaviors. So a lot of harmful substances are around addictive behaviors, aren't they? And one of the issues that I have is with those people who are on opioids. And there's been quite a lot of evidence out. Let me just kind of run through some of these slides. I'm just going to talk to you very briefly about smoking. First of all, there's this really good paper here, which was published in the Foot, about the effects of tobacco on the foot and ankle procedures. And the outcomes. So what we do know is people who smoke are much more likely to have non-unions, and also the people who smoke have an increased risk of infection, and also in the setting of diabetes and ulceration, they're much more likely to have an amputation. So, smoking is a harmful substance. And in terms of lifestyle medicine, we're in the perfect position to encourage people to stop smoking. And in fact, I'm usually very blunt with patients about this and tell them that they have to stop smoking. It's not that I won't operate on them, it's just that they might lose their foot if they continue smoking. And if they need help with it, they can go to their GP. And I'm really quite blunt about it. And a lot of people say, well, I can't, I won't, da-da-da-da-da-da-da. And I guess that is their choice. But when you put it to them that the risks of these things happening after their surgery, you won't believe the number of patients who have given up on the back of me telling them that they have to do it for their own good if they're going to have foot surgery. And it's actually quite a powerful message because it empowers people to have their own best outcome. And I'm not saying it's everybody, but their own best outcome is how I put it to patients. So that's, obviously we know that smoking is a harmful substance. We know that alcohol is a harmful substance as well in outer moderation. So, 14 units a week is the recommended maximum amount. A lot of people don't know what a unit is. So I spend a lot of time describing to people that, exactly how you measure that. Because we know that there's an increase of complex regional pain syndrome with people who are alcoholics. The role of renal and hepatic clearance of the pharmaceuticals that we use in foot surgery can be a real issue. They're much more likely to have a fall. They have altered sleep patterns, dehydration of VT and DVT risk. Now, another very sad story, a long time ago when I was training, had a patient who was booked in for a revision of a fusion that hadn't fused. She came in and she had a Charcot joint. And we didn't operate on her because we weren't expecting this 40-year-old to have a Charcot because she had no history of diabetes. And it turned out that she was an alcoholic, unbeknown to her own husband. And very sadly, she passed away very soon afterwards due to the alcoholic complications. But the first indication that something wasn't right with this lady was a non-union on a surgery. So, so again, this is something that we need to be well aware of. And then moving on to opioids. Now, I listened to a really good training session, which was put on by the British Society of Medicine, who I'm a member of as well. This lady, Dr. Jane Quinlan, about managing pain after surgery. And she was, she's a pain specialist, and she was saying that long-term use of opioids, those people on long-term use will often complain of severe pain. So the opioids clearly aren't working. And that they have poor health in many other ways, and they're very inactive as well, often unemployed. And they have higher healthcare utilisation because they have complex other problems as well, poor quality of life. And again, postoperatively, this puts an increased risk of infection or revision or length of stay. And I know that I've had several patients who have been recovered addicts. And then when we try and use the oral analgesics, which are the ones which we can prescribe, they quite often don't get the benefit of those because their pain receptors have been destroyed by their addictive nature or addictions in the past, and they can be a real problem to manage. So there's a real movement because there's sort of chronic overuse of opioids, and there's a bit of a crisis going on. So there's a real movement to move people away from being regular opioid users, and so that they work much better in sort of post-operative use, where we would prescribe for 3 to 5 days. And one of the things that I do with my patients is I manage their expectations post-operatively, and it's just amazing how you can implant an expectation into people about how much is going to hurt or not going to hurt. Because a lot of people come and say, oh, I've heard that bunion surgery is really, really painful. I don't want to do all the rest of it. I said to them, okay, this is what my patients tell me, and this is what I'm going to tell you. My expectation is you need painkillers for 2 days. 2 days. And then after that, you might just need some paracetamol when you need it. But everybody's different. You might need a bit longer. But take it for 2 days, and then just take what you think you need. Not the whole prescription. Take what you think you need, and you'll be amazed at how many people who come and say, "I didn't have any pain at all, none at all, none," because I've told them it's not going to hurt them.
It's amazing how you can manage expectations with just a few words.
It's just amazing. I mean, it doesn't work for everybody. Everybody's experience is different, but generally, this is what I'm finding with patients, that you can implant the expectation just by telling them confidently that's what you expect. Anyway, that's slightly off the subject of using opioids. This is the problem with using opioids. What will happen and why they become less effective post-operatively. So I'm just going to scoot through that a little bit and just talk to you very briefly on our last subject, which is sleep.
So how is sleep then so important with relevance to podiatric surgery?
Okay, well, yeah, I'm a real sleep fanatic. Because I have suffered from poor sleep in the past, and I've read all sorts of books. There's some really, really great things out there. And again, I listened to a podcast. It was part of the Royal Society of Medicine, a sleep professor. And I'm just thinking, I've got some notes here. I had a little quote from here, which I was going to quote to you. And there are certain things which you can do which change things. How is it you can never find it when you need it? There was a difference between sleep deprivation and insomnia. So I'm an insomniac. It's not that I don't have the opportunity to sleep enough, because I give myself the opportunity, but I often wake in the night and have, my head's buzzing with things. So I tend to be an insomniac. But there are certain things which you can do which will really help with setting your sleep patterns. And one of those is sleep disorders. This is the chap that I was listening to. When he looked at what stopped people from sleeping, they looked at noise, light, and temperature. Now, which of those things do you think, Nicola, is the thing which disturbs people's sleep the most?
So I would have thought, oh gosh, that's tricky, because you could often sleep when it's light, but if it's really noisy, like beyond a reasonable amount, that is very difficult. And what was the last one? Is noise, light, and temperature. Now, some people you hear as well, when it was hot weather and everyone's just like, oh my gosh, the fan is blowing even hotter air back at me and I can't sleep. But then conversely to that, the cold is horrendous. I would have thought actually noise would be the top of the three.
You're absolutely correct. So when they did this study in a hospital setting, they found the one thing that stopped the key thing that stopped people getting good night's sleep was the noise of other people talking.
Wow.
You know, on the wards, it was the noise of other people talking. So all of those things are important. So the advice is that you do need to have a cool bedroom, you do need to shut out all light, and you need to stop all the noise as well. So this is why I have this obsession with the electrical devices in our house, because my husband loves to run them when it's on economy 7, when the electricity is cheap. So
I have to show you
have
something.
the dishwasher going ping, ping,
In that
ping
case.
in the night, and I have the tumble dryer as well. So all of those things are things which might disturb your sleep. So some of the things which are good habits to do is to, the sleeping arrangements is about, your noise and your lighting and temperature. So one of the key things is to have a set time you get up in the morning. Now, this helps to set your circadian rhythms around the sunlight of the day, and it also means that you will become tired at a more regular time at night. Whereas if you get up at different times in the morning, then you're more likely to have a disturbed night. So that was something which I found really, really very interesting, is that it's the morning rising, which is one of the most important things. And the other one was reducing the drugs which you take to try and make you sleep, because actually they don't really work either.
I mean, they do that in the army, don't they, about like sleep deprivation and stuff. And there's something about circadian rhythms versus the amount of stress and cortisol that your body would then release, I'm sure. And actually, and this is promotional, but funny you should say about sleep and about noise being the one thing. I actually have these, and I don't know if you can see them very clearly.
Are they earpods?
It's called Loop, and these are like tiny little silicone things. They're like little noise reducing, cancelling things, and it's exactly the same thing. You find that noise is has such a huge impact on your sleep. If you have absolute silence and like blackout curtains and just the right amount of temperature, you can really get a full night's sleep. Maybe that's why Premier Inn do so well.
Maybe it is, yes. So I think that what we have done this evening is we've had a romp through lifestyle medicine. As I said, I unabashedly promote the British Society of Lifestyle Medicine because I think they're a wonderful society. They do lots of webcasts, they do podcasts, they do educational videos and things that you can link into. So they've got a really nice website as well. So I would recommend anybody to just check them out. It's been a journey for me. I've learned a lot of things, and it's actually confirmed a lot of things which are kind of core values to me. And I guess I've got to that point in my career that I'm unashamed of adopting all of these things and saying this is what I'm doing. Maybe it's not core medicine, but I feel it's core to my practice in terms of managing my patients. And I kind of encourage everybody to adopt as much of it as possible themselves. So I don't think we've had any questions, Nicola. Either we have sent everybody to sleep, or they're so overwhelmed by the information that we've given them, they don't know where to start asking.
Well, I think either way, we've gone through quite a lot though, haven't we, really? And I think it's kind of been a whistle-stop tour over different subjects that are actually very broad. You could literally go on for probably about an hour per each one.
On each one, yeah. Absolutely. But it's an introduction to the policy, to the principle of it. So thank you all very much for listening. I know this is going to be recorded so people can catch up with it again if they want to do that. I did have a colleague of mine who is currently living in New Zealand asking how she was going to be able to log into it. So I guess she might be catching up on the video recording rather than listening to it live. So again, thank you very much for attending, all of you, and we will see you again shortly.
Yep, we will see you again soon. Thanks, guys.
Bye.